Assalamu alaikum. Hello and welcome all from all over the world. Thank you for joining us today, Friday, June 10th. And we'd like to welcome you all to the second NERD conference, or to give it its full name, the Neurological Rare Disease. We're so happy that you could all have joined us. We'd hoped that it would be in person, and inshallah next year we will have it in person, but we had a very successful meeting last year virtually, and we're looking forward to 2 days of education and innovation and fun and discussion on neurological rare disease. My name is Gerard Moore, and I'm the technical support manager for today. So you are now live on the NERD portal. You can see the auditorium where you're listening to us. You also have the exhibition area where you can go and visit our sponsors. And you also have various other activities on the platform. So throughout the 2 days, we encourage you to visit all elements of the NERD platform. The event is accredited, and you will receive your CME certificate 1 week after the event. You will see in the auditorium a questions box. Please do feel free to type any questions or comments that you have for the moderators, who I will introduce shortly, and they will put it forward to the speakers in panel discussions that are pitched throughout the 2 days. So please feel free to make any comments or questions. If you have any technical issues, you will see on your screen there is a yellow man with a headset on, similar to me. You can click on that and you can ask any technical issue that you may be having with connections, audio or video, and that will come through to our IT team that will help you. So that's enough housekeeping. I will now hand you over to the two co-chairs and moderators for the second NERD, Dr. Jihan Suleiman, who's acting division chief of pediatric neurology at Tawam Hospital in Al Ain, who has really led the scientific program both in last year and this year, and is a real driving force in the UAE on neurological rare disease. And Dr. Ahmed Shatila as well, who is consultant neurologist adult at SSMC, who will be co-chairing and has also had significant input scientifically to this event both last year and this year. So thank you to those two co-chairs for organising such a great event again. And I will now hand the floor to Dr. Shatila to give the formal opening. The floor is yours.
Thank you, Gerard. First of all, assalamu alaikum, everyone. It is with great pleasure, and it's an honor actually to host the second annual Neurological Rare Disease Forum that we have. It's always a pleasure working with Dr. Jihan Suleiman. Without her support, this conference could not come to fruition. I would like to thank all the speakers who've taken out of their valuable time to come speak to us today about a host of multiple topics. But finally, I'd like to thank everybody, the audience, because without your support, none of these events could ever come possible. I'd like to also thank our sponsors. Again, without their support, and never-ending education for these rare diseases, we may not actually have these conferences. I'd like to thank Biogen for being a diamond sponsor, Roche and Novartis for being platinum, Biologics, Sanofi, and Genpharm for being gold sponsors, and then TR Pharm for being silver sponsors. Next slide. We have a very interesting agenda today. As you can see, it's, as Gerard had mentioned, it's broken up into two topics or two groups. The first group of lectures will be talking about SMA. We'll be starting with nusinersen in adults living with SMA, updates and learnings from clinical practice with Dr. Tim Hagenacker from University Hospital in Essen, Germany. Then we have nusinersen in SMA management with over 7 years of information. This is going to be given by Dr. Eugenio Mercuri from Polinici, Gemelli, Italy. Then we're going to open the floor for panel discussions. And then finally, we're going to have a lecture on Evrysdi, New Hope for People with SMA, given by Dr. Vivek Mundala from the UAE. Then we're going to have a quick break, and we're going to go to the second aspect, The neuroimmunology, we're going to start with challenges in neuromyelitis optica, spectrum disorder, NMOSD, diagnosis and treatment. This is given by Dr. Michael Levy in Mass General Hospital in the US. And then we're going to have a pediatric multiple sclerosis lecture given by Dr. Raed Rouhani from Emiria Hospital in Kuwait. And then finally, we're going to have the treatment diagram of myasthenia gravis given by Kelly Gwathmey from Virginia Commonwealth University in the United States.
And with this, I will move to the next session, which we are still in the SMA. And our next speaker is a friend and colleague, Dr. Vivek Mandada, who is a consultant pediatric neurologist here in the UAE, in Dubai, in Midcare Women and Children Hospital, as well as ASTA-DM hospitals. So Dr. Mandada completed his subspecialty training in pediatric and neurology and pediatric neurodisability in UK, where he also worked in a number of hospitals, including Great Ormond Street, Royal London Hospital. He moved to the UAE in 2018, and he was really the first pediatric neurologist to administer the gene therapy for patients with SMA. And he built up from there to become really the one with the greatest experience in giving the gene therapy. He's looked after from the region by different patients from different countries to get the gene therapy, and he has probably more than 20 patients. Today, we will hear him talking about Risdiplam, Evrysdi, a new hope for patients with SMA. Thank you, Vivek, and welcome. For the audience, please remember to type your questions in the question and answer, and we will address questions to Vivek at the end of his talk immediately.
Right. Thank you very much for this introduction, Dr. Jahan. So moving on from news in ASEAN, and we're talking about another drug which is recently available to all of us, especially in the UAE. Called Risdiplam, which is known in the market as Evrysdi. Now, just a disclosure, I'm not talking about any clinical experience here on Risdiplam. I'm going to talk about the mechanism, how it works, and some of the information on different trials to see how useful it is. Because, as I said, for most of us, this is a very new medication available here in UAE and around the world. So I'm sure you know by now, but just to recap that how different the SMN1 and SMN2 genes are. And as you can see in this middle exon 7, it's just this nucleotide change from C to T, which makes that difference in the SMN1 and SMN2, which makes SMN1 produce more functional proteins. As you can imagine, you need all these exons, a continuous chain 6, 7, and 8. So this red, yellow, and blue on the left side make the full-length protein. So this is the mRNA constituting all exons and then eventually producing a functional protein. But what is missing in SMN2 is that exon 7, because that's not kind of transcribed on next to mRNA. And there is splicing mechanism again makes the infunctional protein very less, 10 to 20% only, having these all three exons 6, 7, and 8. And that's why SMN2 only contributes to very little functional protein. And this is what is the genetic of SMA, as you can imagine. Now, the whole idea about giving Risdiplam, as you know, the gene therapy is targeting SMN1, is replacing SMN1. But what we are doing here is, by some mechanism, we are trying to include this exon 7 in the full-length mRNA so that you can produce more functional protein. And this is done by Risdiplam as it attaches on two key sites on exon 7. One is the end of 5S, and there is something called, sorry, yeah.
Yeah, so your audio is a little bit breaking up. Can you maybe move closer to your router, or maybe can you just remove your earpods, because we're finding some audio breakup in your presentation.
Oh, sorry. Is it better now?
Yes, that seemed a little bit better, yes.
Okay, Sorry about that. If I missed some part, I'll just go back. So risdiplam, the idea is to include the exon 7 in this process so that when you have the full-length mRNA, you include exon 6, 7, the functional SMN protein is produced. So risdiplam attaches to the two key sites of exon 7 to include that in the splicing. So one is the exon splicing enhancer, which is called this ESE2, and other is this 5S end of exon 7, and that facilitate the exon 7 inclusion, and eventually you get this more of a SMN functional protein. So it acts on this SMN2 gene, as you can see. Going into more details of how it does, as I said, so it binds into two sites, and the binding of the 5S end of this intron of, so there are intron and exon, as you know. We just, in the splicing mechanism, you omit the introns and you just get the exons. So the 5S end of this intron improves the recognition by SNRPs. Now the SNRPs is like ribonucleotide proteins, the RNA and the proteins, which helps in the splicing mechanism. And the unique specificity of this binding to two sites increases the level of full-length SMN mRNA. So you get the pre-mRNA, and then what you do in the splicing is just take off the intron and leave the functional exons. And because of these binding sites, you are including the exon 7, and that's why the from the pre-mRNA and the ribosome complex, or SNRPs, you get a full-length mRNA which includes exon 6, 7, and 8, and that eventually then produces the functional protein. So risdiplam is then increasing the level of functional protein SMN, which otherwise the SMN2 will not produce in that quantity. So in summary, the mode of action of risdiplam is a selective splicing modifier for SMN2, which is designed to bind uniquely to SMN2 pre-mRNA, which promotes the inclusion of exon 7, and then hence the production of full-length SMN2 mRNA and functional SMN protein. We have different trials, and we're going to discuss these 4 trials, which have included patients from different clinical perspectives, different kind of presentation and the types. And overall, it's been studied in more than 450 patients as a part of large and robust clinical trial program in various programs, and they're named after fish programs. All the programs are called jewelfish and firefish and so on. And all these studies have shown clinically meaningful improvement in the motor functions in the people with varying ages. As you can see, where the programs have included children of different ages and different disease severity, and they have tried to include all types, including the kind of symptomatic children to type 1, type 2, and type 3. As of August 20, it was the first and only approved medicine to be used for SMA that can be taken home. Now, you have just heard about nusinersen. The children need to come to hospital, or the adult need to come to hospital every 4 months, and they need to take the intrathecal medication. The gene therapy is also hospital-based therapy, but again, the cost is too high. And this medicine actually you can take home, but it has to be taken orally every day. And it has a systemic distribution, hence, and is licensed for treating all the types of SMA in adults and children anywhere between 2 months and older. Now, this is a snapshot of all the studies which I was just talking about. As you can see, firefish, sunfish, jewelfish, and rainbow fish. So in summary, the firefish, which is still the extension, which includes the type 1 SMA. Now, the part 1 was to study the pharmacokinetics and pharmacodynamics of the risdiplam and to get the dose. Part 2 was the study to understand the safety and efficacy of risdiplam at the dose selected from the part 1, which included 41 patients. This was for type 1. Then for type 2 and 3, there was sunfish study similar to, again, firefish, and they had 180 individuals included in the part 2 to know the efficacy of risdiplam for type 2 and type 3. There is a rainbow fish, which is used for pre-symptomatic children, and so far they have included 25. And there is a jewelfish study, which is for non-naive patients, let's say those who have had gene therapy and now want to get this risdiplam. So it's again studying the safety and tolerability of risdiplam, who have been previously participated in the studies with other kind of medication. So let's discuss, and again, the firefish and sunfish, which was used respectively for type 1 and type 2 or 3, have both met their primary endpoints as of now. And how we monitor, you just heard about different scales. So Dr. Jayan and Prof. Mercury was talking about like Chopin-10, which is most widely used motor scales, RULM scales, Bailey scale, there is Hammersmith infant scale, there is Hammersmith functional motor scales, and so on. And these scales were included in these studies as well. When it comes to Firefish, which is a part two, which was a multi-center global open label study, the primary endpoint was a proportion to see the proportion of infants sitting without support for at least 5 seconds at 1 year of age, as assessed by the gross motor scale through the Bailey scale. Now, as you know, these children will not achieve this milestone, and they want to achieve they want to see these primary endpoints, and also to study the safety and the additional key points. So, in summary, what was the result? 29% of the children, 12 out of 41, were sitting without support for at least 5 seconds by the age of 1 year. This is good achievement. Risdiplam treatment led to a significant improvement in the motor functions, and look at the p-value, was quite significant. Infant achieved motor milestones such as sitting and standing. That would never, you would never see that in untreated children, especially in type 1, because Firefish is for type 1. 93% were alive, and 85% of infants were event-free. Now, what the event-free means is no permanent ventilation, that no tracheostomy, or BiPAP not more than 16 hours per day continuously for more than 3 weeks, or continuous intubation for more than 3 weeks. So this is very significant because as you those who are dealing with SMA, they know that all these SMA1 children eventually end up with respiratory comorbidity, needing ventilation, tracheostomy, and so on. And these children also have the swallowing difficulty. They often get this gastrostomy. But as you see, that 95% of the children or infants were alive, maintaining their ability to swallow even after 12 months of the treatment. 49% of the infants did not require hospitalization during the 12 months of treatment. And there was no any drug-related safety finding which led to withdrawal of any candidate in this study. We'd often see the side effect of upper respiratory infection, those who are being treated with risdiplam. So pneumonia and URTI-like symptoms are very, very common. And this is not, this was actually seen in almost half of the children, upper respiratory infection, pneumonia 39%. Fever is one of the more common side effects as well. And the other ones are like constipation, nasopharyngitis, very less commonly seen. Now, the incidence of serious pneumonia was declined by approximately half between the first second. So as you move on with the treatment, the incidence goes down, and the skin events were non-serious, and no risdiplam-associated ophthalmological findings were seen in the study. Moving on to the Sunfish trial, which is used for type 2 and type 3 for any children or adults aged between 2 and 25 years. And the inclusion criteria was type 2 ambulatory and non-ambulatory type 3 as well, and those who have the confirmed genetic diagnosis of SMA. The conclusion from Sunfish trial, which was used in type 2 and type 3, as you can see that the motor function measure, 32-item motor function measure, and the revised upper limb module scores showed the risdiplam significantly improved motor function after 12 months versus the placebo. This was again control study. Risdiplam also improved the independence in the activities of daily living using the novel SMIS method. And no treatment-related safety findings have led to withdrawal of any candidate in the Sunfish trial. So, in summary, the risdiplam was the first treatment to have positive pivotal placebo-controlled data in the broad population of children, teenager, adults, preserving and potentially enabling the motor function independence for patients with type 2 and type 3, non-ambulant type 3. And this is very important because, you know, this is a progressive condition, and often children will lose their, abilities and motor functions, and this is quite encouraging. Similar to the Firefish, we have seen these side effects in the Sunfish studies as well, most common being the upper respiratory tract infection, nasopharyngitis, and so on. But again, there was many significant side effect as such. So 100% survival was there, and 100% participants had no drug-related safety findings leading to any treatment withdrawal. Moving on, I'm just going to explain how the drug is available in the market, how you and the dosing, and just I'll touch base on the current PSP program which is available in the UAE at the moment. So the risdiplam or Evrysdi comes in the powder form, 60 milligram. All you have to do is add the 79 ml of the sterile water to make a solution of 80 ml, which is the amber color bottles to be stored in a refrigerated temperature. And the strength you get is 0.75 milligram per ml. There's a syringe available, two types of syringe, and it can be given by mouth, or if the child is having feeding tube or gastrostomy, you can give it through that as well. The shelf life is 64 days after you make the drug. And if it's a dry powder, it can last for 2 years. The price, if I have to tell you rounded figure in the dirham, it's nearly 50,000 dirham to purchase. And this is the price in the dollar, which is on the screen. The dosage for younger children who are less than 2 years but older than 2 months is 0.2 milligram per kilograms, and this is daily, of course. For children over 2 years of age but less than 20 kg, the dose is 0.25 milligram per kilogram is the daily dose. And anyone above 20 kg, it's a rounded dose of 5 milligram daily. What about the cost, yearly cost? If you calculate an infant who is, let's say, weighing 8.5 kilogram, a 6-month-old, the daily dose, if you calculate accordingly, like 0.2 milligram per kg would be 2.3 ml. Now, this is in ml I've calculated, not milligram. So this is 2.3 ml, for which you need 1 bottle per month, because you get the 80 ml bottle. And hence, for 1 year, you need 12 bottles. You can do the maths, of course. For a child, let's say 4-year-old weighing 17.2 kg, you need 5.7 ml, which means you need nearly 2.3 bottles or 28 bottles if you round it up. And for an adult, because the round-up dose is 5 milligram, so 5 milligram is like 6.6 ml every day, which means you nearly consume 2.5 bottles and hence 31 bottles needed per year. Now, I've just told you the price, and then you can calculate the price for per year. It's a costly affair, as you can imagine. And to help access the medication, especially in the UAE, the company has launched a program, a patient support program, which we call it as a Hayat patient support program. For those clinicians who are working in UAE, I'll just give a brief about what and how this program works. Because I have enrolled a few children on this program as well. It's quite easy, and to get the access, especially for a whole year for these children. So anyone who is insured with a limited coverage that hinders the patient, receiving the full duration, those who are practicing, how the hurdles are for the insurance to get anything for the congenital kind of conditions. You just literally bang your head, especially of working in a private setting. Even those who are insurance with the co-payment and cannot afford the co-payment, because even for 50,000, one of my patients had to pay like 12,000 just for 1 bottle. And of course, it's not affordable for most of the patients. And even for non-insured patients who are paying out of the pockets, for all of them, this program is there. Now, how it works is there are 4 limbs who are kind of contributing for the finances to access the risdiplam for a whole year. One is the patient itself. Now, I'll tell you how they assess the patient's contribution for this program. Next limb is the charity. Next limb is Roche itself, the company manufacturing Evrysdi, and the insurer. So charity, patient, the company, and the insurer. These 4 entities fund this 1-year supply for risdiplam. And there are various kind of patient affordability program available. So there are many products for oncology, there are many products for hematology. In terms of neurology, Evrysdi is one of them, and the program is called Hayat Patient Support Program. Pretty easy because it's taken over by a third party called Manzil, who does all this work for us. And the eligibility for the individual to go into this program is anybody who is resident or national of UAE, or those who are having a resident visa for UAE, who have been diagnosed or having a pre-existing condition of SMA, and they should have a valid prescription for FSD, and the referral physician. Of course, you need the referral forms and the physician, treating these children. Now, the financial eligibility, what happens is the Manzil then assesses the financial eligibility of the parents or the patient by examining through multiple factors. There is a dedicated kind of a person from finances who looks at their income level, the country-specific standard of living, the assets, expenses, everything, and then they determine the patient's financial contribution towards the treatment plan versus the financial support needed in order to secure the treatment. Now, there are various themes here. One of my patients needed to buy one bottle to get rest of them, and again the patient could do that by raising the funds to charity as well. So it's not that difficult. If you can imagine somebody need to buy 12 bottles versus one bottle is still much easier. So the process goes like this. The referral and consent is needed from the patient, and the forms are very, very easy to fill in as well. You just send the form to a single email to Manzil Hayat program team. The team onboarding then appoints a coordinator, which then contacts the patient, explains the program and financial assessment procedure, and they then call for the required documents for the enrollment. A financial assessment is done. The financial report is then shared, and then the patient is updated for the eligibility, and then the charity application is put forward, the fund is secured, and the medication is then dispensed to the patients. And we are dispensing through hospital because, again, it's easier for the hospital pharmacy to reconstitute the medication. So that's all I wanted to tell about. Again, these are the forms needed for this HIAT program. I won't go in much detail. Those of you need information, I'll tell them later. So doing now what patients need next is the key. And this is all from my side. Any questions are welcome. Thank you.
Thank you, Vivek. Right, so let me check if we have any questions. Yeah, so there is a question about the SMA rates, or I guess prevalence or incidence in the UAE. We need studies for this, right?
I know we need more collaborative work. I've been trying to. I mean, Jihan is a best person.
Registry
we've been
to
discussing that exactly, and we have been discussing through our meetings as well. There's no clear kind of data. We had some paper from Saudi, but we need the data from UAE to calculate the prevalence. I mean, most of our neurologists. So hopefully someday we'll give that answer. But as of now, because my data is quite skewed, as Dr. Jan was saying, I get a lot of patients from outside as well, from outside the country. But yeah, probably the answer is I don't know at the moment.
So there is a question about Hayat program. Is it for 1 year only?
At the moment, yes. So the patient get 1 year supply, yes.
Okay, and I guess there is a question about gene therapy, although I guess because your bio talked a lot about it. Do you think there is there would be need for other therapies? I think it's relevant, like since for patients who receive the gene therapy, do you think they might need, for example, Restiplan as well, if they're still symptomatic?
Well, the honest answer, we don't know. I mean, I've been asking this question to Prof. Mercury. I just met him 2 weeks before as well. The problem is those who are very good clinical condition at the baseline, the gene therapy would work better for them. With more comorbidities and less CHOP in 10, it's really difficult. So what you achieve after the gene therapy is really based on how well clinically the child is. Having said that, because of the PSP program, most of my patients who are resident in UAE want to get that additional just because they're getting it, easily. Those who are coming to me from Turkey or Kazakhstan or Romania, they get Spinraza through their respective governments as a free of cost, and they don't want to miss that. Now, as I said, we don't know the outcome of this dual therapy or combination therapy, really that works or not, because it's very subjective. I myself have been trying to gather that data, but To be honest, if you can afford them, but otherwise, if you have access to gene therapy, if you have blown up all the money,
I
you really
actually
don't
had a patient who came back from US after receiving gene therapy a bit late, like at the age of 9 months. So he was on non-invasive ventilation overnight. I can't remember the Chopin-10 score, but I did suggest using like Risdiplam.
Yeah.
And I think there was concern about infertility that Risdiplam can cause. Is that something that really is coming with
Nothing.
more data?
I don't think we have that much data in adults to study the infertility.
And I guess in somebody with this
which...
clinical situation, I'm not sure that
right.
this is really our priority of.
Yeah. And I'm just like you, Jan, because I can't say no to this, parents. If they want it, okay, they get it. But if they don't have access for the dual therapy, it's not mandatory for them to have it because they already had something in hand. So recently I had a child with AAV9 antibodies positive, but was getting Spinraza. And I said, you don't really have to have the gene therapy if you continue getting Spinraza.
I think we've seen really nice data with all the treatments. So
yeah,
it's like what Professor Mercouri rightly said, use whatever you can afford and whatever is available.
Absolutely. Time is the key in this patient.
All right. Ahmad, do you have any questions or anything to add? I think we addressed all the questions.
You did.
Thank you, Vivek, so
more.
much. Thank you for joining us.
Thank you very much.
Always nice to see you.
Pleasure. We'll see you again. Thank you.
Thank you.
So I'll hand over to you, Ahmed, with the second favorite neuroimmunology session.
Thank you, Dr. Jehan, for the very interesting first session. We got big shoes to fill. Hopefully we'll have a very interactive session as you guys just had. We're going to be starting now session B, the neuroimmunology session. With us today, our first speaker is Dr. Michael Levy from Mass General Hospital from Boston, USA. Dr. Levy, I don't know if you are here or can you hear me?
Hi, Ahmed. Yes, I'm here. Thank you for inviting me.
Thank you for coming. How are you today?
Fine, thank you.
Excellent, excellent. Well, first of all, Dr. Michael Levy is an MD, PhD. He's the research director in the Division of Neuroimmunology and Neuroinfectious Disease. He completed his MD, PhD program at Baylor College of Medicine in Houston, Texas, with a focus on neuroscience. Dr. Levy then completed his Johns Hopkins internship in the Osler Medicine Program, residency in the Johns Hopkins Neurology Program, and a fellowship in neuroimmunology at Johns Hopkins University. In 2009, Dr. Levy was appointed to the faculty as assistant professor at Johns Hopkins, where he started the Neuromyelitis Optica Clinic and Research Laboratory. And in 2019, he moved to Massachusetts General Hospital and Harvard Medical School to develop the research program in neuroimmunology. Clinically, Dr. Levy specializes in taking care of patients with rare neuroimmunological diseases, including neuromyelitis optica, transverse myelitis, MOG antibody disease, acute disseminated encephalomyelitis, and optic neuritis. In addition to the neuroimmunology clinic, Dr. Levy has a special interest in patients with superficial siderosis of the central nervous system. Dr. Levy is the PI investigator on several clinical studies and drug trials for all of these conditions. He is appointed the research director in the Division of the Neuroimmunology and Neuroinfectious Disease of Mass General Hospital. Dr. Levy is focused on understanding how the immune system and the nervous system interact to cause diseases. This includes autoimmune diseases such as neuromyelitis optica, in which the immune system is aberrantly responding to a harmless trigger, as well as Parkinson's and Alzheimer's disease, in which the immune system might be reacting to triggers in the neuroenvironment. In his lab, they genetically modified mice to model these neuroimmunological interactions and then develop strategies to re-educate the immune system towards a better outcome. Today, Dr. Levy is going to be talking to us about, challenges in neuromyelitis optica, spectrum disorder, NMOSD, diagnosis, and treatment options. Dr. Levy, thank you very much for coming today. And without further ado, the virtual floor is yours, sir.
Thank you. And thank you again for inviting me. My topic today is all about neuromyelitis optica spectrum disorder. Just a few disclosures before we get started that I have received consulting income from various companies involved in developing drugs for this disease, including Alexion, which partially sponsors, I believe, partially sponsors this event. So neuromyelitis optica is a very disabling disease. This is one of those conditions that you don't want to miss because the consequences are devastating. Here's my patient here. She was on the cover of a newspaper because she was a star basketball player before she developed NMO. You can see the timeline here over the course of 4 years. This young lady went from an active basketball player to having visual impairment, to being confined to a wheelchair, and ultimately dying. And although the mortality rate for this disease has declined from 30% in 1999 to only 7% now, this is still a very disabling disease, especially in cases where the diagnosis is delayed. And the reason for that is that each attack of NMO leaves behind significant residual damage. So it's hard to recover from each attack. And most of the disability accrues with each attack. And that's what makes prevention so key. So if you can identify your patients early, distinguish them from other demyelinating diseases like MS, and treat them effectively, then you can prevent this decline in function and death. And let me introduce you to one more person. This is Dr. De Vick. He lived in the 1890s. He was the one who first coined the name neuromyelitis optica. People still called it De Vick syndrome long after he coined that term. But now we've gone back to neuromyelitis optica, and now we've added spectrum disorder because of our understanding of how this disease works. So now people use these terms synonymously: De Vick's disease, neuromyelitis optica, and NMOSD. Historically, when I was going through medical school, the way that we learned about neuromyelitis optica was on the spectrum of localization. So if you think about multiple sclerosis as being a demyelinating disease that involves the entire neuraxis, including optic nerves, brain and spinal cord, and transverse myelitis as being, by definition, confined to the spinal cord, neuromyelitis optica fit in this spectrum as being the disease that affects mostly the optic nerves in the spinal cord and some brain stem. And in fact, we used to believe that NMO was supposed to spare the brain, and that if you had a lot of brain disease, that it was probably multiple sclerosis. So in the initial plan for the criteria, the diagnosis included a requirement of optic neuritis, a requirement for acute myelitis, and then the third requirement asked you to rule out all of the other diseases like sarcoid and multiple sclerosis that could confound the diagnosis. That was how things started. It was in 2004 and 2005 that colleagues at the Mayo Clinic identified a blood biomarker for this disease. In 2004, it was reported in the Lancet as an indirect immunofluorescence assay. That allows you to take the serum of a patient, apply it to a composite of mouse tissue. This, for example, is the mouse cerebellum, molecular and granular layers, mouse midbrain, mouse smooth muscle. And there's many more tissues on this slide that the Mayo used. And they would wash it over with human serum and add secondary antibody for the human FC. And wherever the human antibody bound, it would create a pattern that looks like the one you see on your screen for anybody who had neuromyelitis optica. That's what was identified in 2004. And then quickly, within a year, this group at Mayo identified that the antibody that created this pattern would bind the aquaporin 4 water channel. They could show that commercial antibody to aquaporin 4 here on the left in the brain, kidney, and stomach, co-localized with antibody from patients here in red in those same tissue areas, and the co-localization is shown as yellow. This has since been confirmed in multiple labs. Now we use a really good cell-based assay to confirm presence of the aquaporin 4 antibody in patients with neuromyelitis optica. This antibody test is nearly 100% specific. That means that if you ever find a patient who tested positive for this antibody using a cell-based assay, you can pretty much guarantee that that patient has or will have neuromyelitis optica. We don't use it as a screening test because the disease is only prevalent in about 1 per 100,000 people, but we do use it in anybody who comes in with a demyelinating disease, even in a pattern consistent with MS or MOG or any other disease, but especially of optic neuritis and transverse myelitis, because if they test positive, your diagnostic workup is done. If they test negative, the sensitivity is only about 80 to 85%. So there's still a 1 in 6 chance that the diagnosis was missed. And we do recommend repeating testing once a year for 3 years as needed. Now, another way to think about NMO beyond an aquaporin 4 disease and beyond a disease of localization is on 2 other spectra. One is called the recurrence rate, and one is humoral autoimmunity. Recurrence rate we just defined as the number of relapses over a period of time. You can see there's a large range for multiple sclerosis. The average is once a year, but many MS patients have relapses sooner than that, and some have more often than that. Patients with transverse myelitis almost always have 1 attack. And then you could see rheumatologic diseases here and neuromyelitis optica here, high on the recurrence rate axis. Humoral autoimmunity we define as presence of complement in the tissues from lesions in the spinal cord and optic nerve. You often see complement deposits. You'll see antibodies, IgG and IgM, around the blood vessels. You see presence of granulocytes. Those are neutrophils and eosinophils. You almost never see eosinophils in the tissue of a demyelinating disease lesion, except in neuromyelitis optica. And these patients are usually responsive to plasma exchange. I'll go into treatment later. This is just to point out that there really is a strong humoral autoimmunity component to neuromyelitis optica. Now, over the years, as we've had access to the antibody test, this circle has moved in 3 important ways. So first, you'll notice it moved away from multiple sclerosis. We don't accept diagnosis of both MS and neuromyelitis optica. The way we've defined these 2 diseases is that they are immunologically distinct. Neuromyelitis optica is due to immunity against aquaporin 4, and multiple sclerosis is a different disease altogether. The second direction that this circle moved is down on the recurrence rate. That's because we have good therapies now. I think if you consider only cases after 2019 when drugs have been approved for NMO, I think it would move a lot lower. And then thirdly, there's a larger overlap that we now recognize between neuromyelitis optica and rheumatologic diseases like lupus, Sjogren's, psoriasis. These diseases overlap by about 40%. And that's both in the patient themselves and in the patient's family. You'll often hear a strong family history of rheumatologic diseases in NMO. Using this antibody test, we can determine the prevalence of NMO throughout the world. And what's really interesting to me is that if you look at per 100,000 population, the prevalence of NMO is about the same everywhere in the world. In the US, it's about 4 per 100,000. Australia, almost 1, Iran, almost 2, UK, 1 to 2. You can see everywhere it's somewhere between 1/2 and 4 per 100,000, with one exception. And the exception is in the small French colony of Martinique in the far eastern Caribbean here. 90% of the population of Martinique is African heritage. We believe that that plays a role in the susceptibility to NMO, and the incidence there is much higher. It's 10 per 100,000. And we know that that number is accurate because they have a national healthcare system that enrolls everyone. And so we know the exact denominator as well. Now, aquaporin 4 is a water channel, but it turns out that the water channel function has nothing to do with the disease. Aquaporin 4 is expressed on astrocytes. In the central nervous system, it's the only cell that expresses aquaporin 4. And generally, we think of the expression as being polarized, and that is that you have aquaporin 4 expression at the end feet that wraps around an axon at its synapse, and then around a blood vessel. And it helps to shuttle water back and forth as electrolytes move across the astrocyte as well. And as I said, the function of the water channel has nothing to do with the disease. It turns out aquaporin 4 is just a naive target of an aberrant immune response. It's the immune response that's incorrect that attacks aquaporin 4. In this panel, I show you where the aquaporin 4 is expressed. Again, it's on the end feet of the astrocyte around the blood vessel wall. The blood and antibody to aquaporin 4 are generally concentrated within the lumen of the blood vessel. And the aquaporin 4 is on the outside. So generally, the antibody and immune cells to aquaporin 4 don't have easy access to the water channel. It's something that's on the outside of the blood vessel wall, and aquaporin 4 helps form the blood-brain barrier within the central nervous system. Now, aquaporin 4 is also expressed in other tissues. It's found in the stomach, as I showed you, kidney and other organs. But disease against aquaporin 4 in NMO is only found in the central nervous system. Our patients don't have kidney disease or stomach inflammation or anything else. And why that is, we're not exactly sure, but even in animal models that develop immunity to aquaporin 4, the manifestation of the disease is entirely confined to the central nervous system. Another interesting fact about aquaporin 4 is its expression within these things called arrays, orthogonal arrays. This is aquaporin 4 under an electron microscope. And the really neat thing is that these channels form tetramers that make these very beautiful rectangular arrays. And it turns out if two aquaporin 4 antibodies bind side by side on these arrays, it's perfect spacing for complement fixation. As I mentioned in the beginning, there's a strong component of complement deposition in the tissue, and I'll show you some of that. And we think that the reason it's so sensitive to complement, in part, is because the antibody binds side by side and is perfectly spaced 60 angstrom apart to bind the C1q complement component, which initiates the complement cascade. So now that we have the aquaporin 4 antibody, we've been able to update the criteria. In 2006, so this is just 1 year after the aquaporin 4 antibody was discovered. Within a year, it was already added as a supportive criteria. You still had to have optic neuritis and transverse myelitis, but now you could use this antibody to help support the diagnosis of NMO. We've since updated the criteria, and I'll show you those in a minute. First, let me show you a few examples of MRIs from patients with NMO. I use these MRIs to highlight particular features of the disease. On the left here is the T2-weighted sagittal view of the spinal cord of a lesion. You can see that stretches from the top of C1 and C2, C3, C4, all the way down to C5. So the T2 extent is beyond at least 3 vertebral lengths, and we call that longitudinally extensive transverse myelitis. And you see that a lot with NMO. The enhancement pattern might be a lot smaller. You could see the enhancement here is only behind C1, C2. But the T2 extent is what we consider when we think about the diagnostic, when the differential diagnosis. So you might see focal lesions in MS, and they might be enhancing, but the extent of a lesion like this, you rarely ever see in multiple sclerosis. So that's really important to distinguish MS and NMO. Let me show you 2 more examples. Here's one in the spinal cord where you could see the enhancement very clearly, right here behind the heart. And the T2 lesion is not as clear, but it's also longitudinally extensive behind that area of enhancement. And then a third example here with another enhancing lesion here in the thoracic spine with a very long T2 lesion here as well. So long lesions on the MRI are commonplace for NMO. Since we have the aquaporin 4 antibody, within a year of the new criteria, we came up with this category called NMO spectrum disorder, because the original criteria and the revision in 2006 required both aquaporin 4 and, optic neuritis and acute myelitis. But when patients presented with one and then tested positive for the antibody, we didn't want to wait for them to have the next attack before we could make the diagnosis. That was silly. We knew it was essentially inevitable because the antibody test was nearly 100% specific. So we allowed for even a single attack to make the diagnosis if the aquaporin 4 antibody was positive. And that allowed for much earlier diagnosis and initiation of treatment. And by 2015, when we revised the criteria, we accepted the antibody as being the most important factor. And if it's positive, then you could have optic neuritis, you could have transverse myelitis, you could have an area poststremal lesion, which I'll show you in a minute. You could have almost anything and make the diagnosis with a positive aquaporin 4 test. In the absence of an aquaporin 4 test, you still have to meet the higher level of criteria of at least 2 lesions in 2 different parts of the central nervous system, and they should have MRI characteristics of NMO, like a longitudinally extensive presentation. In the US, we have lots of options for lab testing. I'm not sure what's available in UAE. I think I've had colleagues send some antibody tests to London or to Germany, or to run them in research labs in the UAE. And they are fairly well standardized and validated. Euroimmune sells a kit, which you can do on your own, which has positive and negative controls and may allow for rapid testing. I do want to caution about a type of test called an ELISA, a enzyme-linked immunosorbent assay, which has a much higher false positive rate, especially with low levels of antibody. We strongly prefer the cell-based assay if you have access to that. I mentioned the seropositive criteria easy now. Anyone who tests positive can have almost any inflammatory lesion in the optic nerve, spinal cord, or brainstem, and they get the diagnosis. For seronegative disease, it's still a thing. We still have quite a few patients who don't really have a clinical presentation consistent with MS, but they don't test positive for aquaporin 4. And so for those people, we really want to be sure we're treating them correctly. We do look for at least 2 lesions. It has to be a relapsing disease. The lesions have to be either in the spinal cord and then also optic nerve or spinal cord brainstem or something like that. We want the lesions to be longitudinally extensive, either in the spinal cord, or as I'll show you, a longitudinally extensive lesion in the optic nerve is also convincing. And ruling out MS is always difficult. There's no blood marker for MS, so we do our best. Longitudinally extensive lesions in the spinal cord go based on the enhancement pattern. In the spinal cord, it goes based on the T2, but in the optic nerve, it's based on the enhancement. Here's an axial cut of the optic nerves. The optic nerves extend from the retina all the way to the chiasm over the course of about 15 millimeters. Half of the length of the optic nerve is in the retroorbital space. A very small portion, 10 millimeters, is through the skull bone, and then another 15 millimeters within the skull. Here's a diagram of what that looks like. Enhancement in optic neuritis can extend to any part of this optic nerve, can even go down to the optic tracts. So if you have a patient with a long lesion in the optic nerves, it's much more likely to be NMO or MOG. And we charted this out among over 30 patients with each condition, where we physically measured the length of the enhancement pattern. And you can see that optic nerve attacks that have longer lesions are much more likely to have NMO or MOG than MS. MS lesions tended to be small, focal, and they also tended to be more in the anterior space, retroorbital. Whereas with NMO, we saw a lot of lesions right next to the chiasm, within the chiasm, or even in the optic tracts. So that should also be helpful in distinguishing from MS. And then there's one thing about NMO that's really unique to NMO that we haven't seen in pretty much any other condition. And that is these area poststremal lesions. Right here at the bottom of the brainstem, on the floor of the 4th ventricle, you'll find the area postrema. This is where a part of the blood-brain barrier is fenestrated to allow access for the brain to the blood directly, and it can trigger a vomiting event. When you have inflammation in that area, and again, it's right here, right where this bright area is on the sagittal cut, what happens is you get about a 2 or 3 week episode of chronic nausea, vomiting, and these very uncomfortable hiccups. And it's so miserable, patients are usually hospitalized They often get extensive GI workup, especially if they don't have a previous diagnosis of NMO. And then it's only on the next attack, which tends to be optic neuritis or transverse myelitis, that when you ask them, have you ever had a 3 or 2 week episode of horrible nausea, vomiting, and intractable hiccups, they say, oh yeah, that happened last year. I was hospitalized, and they'll tell you a story that sounds just like an area post-edema attack. That happens in about 12% of people, and that is unique to NMO. Often these lesions start off in the area post-edema and then grow down into the cervical cord. So it's important to treat these people. If you use steroids, you can often cut short their hospitalization and they'll start to feel better sooner. I told you that complement is involved in NMO. This was demonstrated way back in 2002, even before the antibody test confirmed the diagnosis. What was recognized is all of this pink stuff is complement deposits within the lesion of an NMO patient. They also found IgG and IgM, but look at these patterns of complement deposits. There's reticular and smooth. They're usually around the blood vessels mostly. And then in our lab, we showed that the complement deposits involve the classical complement cascade, not just the alternative pathways. So we had a sense that we could treat with complement inhibitors and really make an impact in these patients. So that leads me to the treatment section of this talk, which includes both acute and preventive. Acute treatment, the way I explain that to patients is, it's like having a fire in the spinal cord of the optic nerve, and you have to put it out. The fire is inflammation, and it's spreading and it's causing damage, and you want to suppress that to prevent any more damage. On the preventive side, after that, you want to prevent lesions. You're really impacting the immune system here. You're not really healing any previous damage, but you're preventing any future attacks from occurring. The standard of care for acute treatment is what we've been doing since the 1980s for multiple sclerosis. And that is, we use methylprednisolone at high doses of 1,000 milligrams daily IV for 5 days, or the equivalent in oral form. If patients don't respond, and most patients with NMO do not respond to steroids alone, we have to escalate to plasma exchange to cycle 1 to 1.5 volumes 5 times, usually every other day. So that requires a 10-day hospitalization. And that's really what is necessary these days to avoid damage from these NMO attacks. How do I know steroids are not sufficient? We did the study. We looked at patients at baseline who already have some disability from previous disease. This line represents their median disability level, where the higher, the worse. At presentation with a new relapse, their disability obviously worsens by definition because they're having a relapse. And after we treat them with steroids and we follow them up in clinic within 6 months, you could see that this median line does not change much. So they had a disability worsening, and within 6 months, they're not much better, despite our treatment with steroids. In fact, we quantified this and found that only 1 out of 3 patients really responded well to steroids. That explains the need for escalating to plasma exchange. My colleagues in Germany plotted the time to plasma exchange as being one of the most critical factors for responding to it. If you're able to start plasma exchange within a day of a relapse beginning, you have a 50-50 chance of recovering back to baseline. And then every few days you wait after that, your chance in red goes down. And the chance in blue of having a bad outcome goes up. And even if you don't want to consider it as either a yes/no type of response, but a yes, no, and partial response, there's partial response even as late as 3 weeks after onset. So we never withhold plasma exchange, but the longer you wait to start it, the less your chance of recovery is. Okay, on the preventive side, we've been using off-label treatment for a long, long time. Now we have 3 new drugs that I'm going to mention, but I do want you to think about how this compares to off-label treatments that we've been using for years prior to these trials. The most popular drug worldwide, azathioprine, has a failure rate of about 53%. And remember, failure rates in NMO are not tolerable. A patient who has a failure may lose vision in one eye, And a second failure may mean that they're blind. So we really don't want to tolerate failure rates. It's not something that you want to measure on a regular basis, like an annualized relapse rate. That's why we publish failure rates, because even one failure can be devastating. And azathioprine is not that good. We looked at mycophenolate, which is sort of the newer generation of azathioprine, and that is a little bit better, with a failure rate of only 25 to 36%. B-cell therapy with rituximab, if optimally dosed, or even if not optimally dosed, has a failure rate of only less than 1/3 of cases. So we're already improving a lot there. But we've done even better lately through the use of new drugs in clinical trials. And I want to show you how they act on this chart here. So on this sketch of the pathogenesis of NMO, you see the T cells and B cells in the bloodstream up here. This is upstream of the attack. They're presumably conspiring, deciding when and where to attack. And then at some point they decide to do it. And the B cells differentiate into plasmablasts and start spewing out aquaporin-4 antibody. So at this point, you have aquaporin-4 reactive T cells, B cells, and plasmablasts, as well as the antibody, all tuned towards aquaporin-4. And at some point, the T cells then invade the central nervous system, drag along with it antibody, granulocytes, complement, and everything else I showed you. Within the central nervous system, the antibodies will bind aquaporin-4 on astrocytes and fix complement. That's what causes the destruction that you see in the biopsy tissue. The T cells, B cells, granulocytes, and everything else cause swelling and inflammation and a lot of other dysfunction. So
5
where—
minutes remaining.
Okay, great. So where are we intervening? We're intervening at 3 places. One is between communication of T cells and B cells. IL-6 is responsible for part of that communication, and blocking it with satralizumab at the IL-6 receptor is one point where we intervened. Second is inebilizumab, which is a CD19 drug. CD19 is expressed on B cells, but also on plasmablasts. So rather than rituximab only removing B cells, inebilizumab also removes these aquaporin-4 producing plasmablasts. So that was trialed. And then eculizumab is a terminal C5 inhibitor, which blocks complement, sort of acts as a missile shield against complement fixation. All of these trials launched around the same time in 2013, 2014, and then reported out in 2019. Here is an overview of those 3 drugs, and I'll get back to the logistics at the end. Let me just orient you to this type of result. This is called a Kaplan-Meier curve. And the light blue line coming down like this is the placebo arm. And every time the line moves down, the patient relapsed. And in this placebo arm, at 1-year time point, at 48 weeks, you could see here that 63% of patients remained in remission, or about 37% relapsed. At 2 years, 50% relapsed. And at 3 years, 55% of these patients on placebo relapsed. In this placebo arm, they were permitted to be on background therapy like azathioprine, and that fits with our observed study with azathioprine and mycophenolate. There's about a 50-50% work of the drug working, or about a 50% failure rate. Now, what about the drug? So this line here is eculizumab. It's dosed every 2 weeks. You could see that there was 1 relapse here, 1 here, and 1 here. So there were 3 total out of 96 patients. And you can see that in the long term, there were no more relapses. In fact, at 1 year, only about 2 or 3% relapsed. And over the long term, 2 to 3 years, it's still less than 4%. The overall reduction in risk of relapse was 94%. This was really, really impressive results. Even in the 3 cases that relapsed here, when I looked at the data, they didn't even have MRI lesions. And that suggests to me that maybe they weren't even real relapses. So we're talking close to 100% effective. How did the other drugs do? The other drugs were also effective, not quite to the degree that eculizumab showed, but satralizumab, which again blocks the IL-6 receptor, you can see the placebo arm in orange here, had a relapse rate a chance of failure, about 40% at 1 year and 50% at 2 years. Again, that's consistent with what we know about background drugs. But if you block with satralizumab, you could see a reduction in risk of relapse here, mediated by on the purple line. The total reduction in risk of relapse with satralizumab is about 55% if you consider seropositive and seronegative. But if you only look at seropositive, it's closer to 75% risk reduction. And then the third drug is inebilizumab, the B-cell therapy drug. This is the placebo curve here in gray. And this study was only done over 6 months, but the failure rate you could see here for the placebo arm was 44%, 56% remission, 44% failure in 6 months in the placebo arm. But in the drug arm, you could see only 13% failure rate. This is even better than we saw with rituximab. So all three drugs proved to be very effective. What about tolerability and safety? Very, very safe. All three drugs with very few exceptions. There were a couple of deaths that were usually due to breakthrough disease of the NMO disease rather than any problem due to the drug. And so in summary, I hope I've convinced you that NMO and MOG, although we didn't talk so much about MOG antibody disease, are different from multiple sclerosis, and it's important to distinguish them so you can get them on the right treatment. Long lesions are common on the MRI. Aquaporin 4 antibodies are extremely specific if they're positive. Acute treatment for NMO right now consists of steroids and plasma exchange, and we have 3 approved treatments for NMO, including eculizumab, inebilizumab, and satralizumab. Thank you for your time.
Thank you, Dr. Levy. Very interesting lecture. It's always a pleasure having you. And Dr. Levy, hopefully you'll be able to stay with us towards the end. We will have a Q&A at the end of the other 2 lectures. Hopefully you'll be able to join us. With that, I'd like to introduce our next speaker. Our next speaker is Dr. Raed Roughani. Dr. Raed Roughani is a consultant neurologist. He's the director of the MS clinic at Amiri Hospital and Encina Hospital in Kuwait. He's the vice president of the scientific leadership group of MS Space. And currently today, he's going to come talk to us about pediatric onset multiple sclerosis. Dr. Raed, the 30-minute virtual floor is yours, sir. Are you here? I see your slides.
Dr. Raed, you're on mute.
Oh.
He's on mute.
Yes, hi. Thank you, Dr. Ahmed, for your kind introduction. Do you hear me?
Yep, I hear you and I see you. And I see your slides.
Good. Well, thank you for your kind introduction, and also thank Novartis for the invitation. It's my pleasure to be here. So the task was given to me is to discuss pediatric onset MS. These are my disclosures, and this is the outline of the presentation. So first of all, I think important to try to think about pediatric MS and adult onset MS. Probably they are the same continuum of the disease, but the age is different. So at the end, probably they share many pathogenesis and also some clinical features, but there are some slight differences. Now, the caveats are usually the incidence and prevalence rates. It's very tough to actually try and look at the prevalences or the incidence worldwide for 2 things, because of 2 things. First, the range age across studies are different. Some studies report 15 or less or 18 or less. And also the diagnostic criteria used in many studies are different. So it's not easy to pinpoint the actual incidence. But roughly, we're talking about 5% of the total population of MS is composed of pediatric MS. And roughly, we're talking about 3 to 10% of MS patients in the clinic are below the age of 18. And MS below the age of 10 is extremely rare. You may see it, but usually less than 1%. The risk factors are probably the same as in adults. Obesity and passive smoking appears very high prevalent risk factors for pediatric MS, and also the EPV infection and low levels of vitamin D and also there, so similar to adult patients. And also the genetic factor with HLA-DRB1 is also present, a risk around 35% in those patients. Again, there's not much difference with the adults. Now, in terms of pathophysiology, there is some difference. There is a dense accumulation of lymphocyte and macrophages in a prominent perivascular distribution with rare B cells. The anti-myelin oligodendrocyte glycoprotein, the MOG, seem to be associated with encephalopathy at onset in pediatrics. And also, when we look at the CSF study, less intrathecal antibody production in pediatrics, and high percentage of neutrophils in their CSF. So this is both suggest prominent activation of the innate immune system. It's very difficult to actually do a pathological study in pediatrics, but this is a historic study. It was a retrospective study analyzing the axonal pathology in archival brain biopsies. So here we're talking about real pathological specimen from 19 children with early MS. And these biopsies were performed for diagnostic reason to exclude neoplasm or other inflammatory disease. And if you compare the 19 pediatric people with the adults, and if you look more into the actual pathology, if you look at the oligoclonal band, you can see around 10% are present in pediatrics, more than 50% in adults. And if you look at the lesion size in the MRI, is really larger and distributed in many areas in a pediatric cohort. So this is tell us again there is intense inflammatory responses. And if you look at under the microscope in the lesions of the biopsied lesions, if you measure the macrophages, you can see in the pre-pubertal there is significant increase compared to the pubertal and the adult lesions in terms of macrophages. Again, there is a significant positive correlation between the acute axonal damage and the number of macrophages within the lesions. In terms of clinical features, typically they are monofocal. However, you may see polyfocal attacks that may occur, an attack after an attack. So the relapse rate is actually higher than the adults by 2 to 3 times. The relapses are really severe, mostly brainstem or spinal. They recover well because of the good brain plasticity at the beginning, and also there is a good brain reserve. However, the accumulation of some of the disability may occur earlier. So they may reach the EDSS of 6 at earlier age compared to adults, though the duration is a little bit longer because the onset is earlier. Now, progressive MS is really rare in pediatric MS. So more than 98% of pediatric patients will demonstrate a relapsing remitting course. And the other symptoms, the pyramidal, the sensory, the bladder are probably the same, with the exception of one feature, which is cognitive impairment, which I'm going to talk in a minute. So cognitive impairment reported in 30 to 50% of pediatric onset MS. And these are usually evaluated by neuropsych testing. And usually the patient who are young with a longer disease duration may be at high risk of cognitive impairment. And there is a good correlation between the MRI lesion loads, especially when they are accumulating the corpus callosum or the thalamus, and the cognitive impairment. And there are many studies that try to correlate the cognitive impairment with brain structural and functional alteration with non-conventional techniques. The domains that might be affected in pediatrics are widely distributed across the cognition, and mostly the abstract reasoning, the processing speed, and the visual spatial function. These are really being disordered quite early in the disease. And this at the end will affect the quality of life, especially the academic and the social activities. In terms of diagnostic, there is what we call the International Pediatric MS Study Group criteria, led by the CRUP group. And there was a revision in 2013 to the older version, which was in 2007. Before I go to the CRUP 2013 diagnostic criteria, there are two things we have to state. First, in pediatric cohort, encephalopathy is very common in many inflammatory disorders. And when we say encephalopathy, it means an alteration in consciousness, whether it's stupor or lethargy, or any behavioral changes unexplained by fever or systemic illness. When we talk about a second attack, usually we have to at least wait 3 months after the incident, the first incident, before we call it as a second attack. You may hear a term called multiphasic ADEM, and this is very rare. So in the past, we thought there is a multiphasic ADEM, but nowadays we think probably these are MS attacks rather than ADEM. And it might happen, but if you're gonna call it a multiphasic ADEM, you have to wait at least 3 months between the two attacks, and usually very hard to find a third or fourth attack. So again, if you have a 3, 4 ADEMs, so probably this is not multiphasic ADEM. This is probably MS or animal spectrum disorder. So let's look at the CRUP criteria for the diagnostic criteria for pediatric MS. If a patient has 2 non-encephalopathic clinical events separated by 30 days and involving more than one area, you can call this MS. And this is probably similar to the adult McDonald's criteria. If a patient has 1 non-encephalopathic episode typical of MS with a typical presentation associated with MRI consistent with the McDonald's criteria, and then the patient have dissemination in time and space, then you can call it MS. Again, this is similar to McDonald's criteria. If a patient has an ADEM confirmed by the encephalopathy without any fever or systemic illness, and then followed by a non-encephalopathic event 3 or more months later, and associated with a new lesion that fulfill the McDonald's criteria dissemination in space, then you can call it MS. So you may have the first attack as ADEM, but the second attack is non-encephalopathic and has lesion characteristic of dissemination in space. Now, you can call a CIS also patient, and then if you have dissemination in time and space, as similar to the McDonald's criteria, you can label as MS or pediatric MS, but this only applies to children above 12-year-old. Now, if you want to apply the McDonald's criteria in children, it's been already done and validated in a large pediatric cohort, and you can see the sensitivity is around 70% and the specificity around 90-60%. So it's a quite good percentage if we want to use the McDonald's criteria. However, we rely on CRUP criteria for those below 16 years old. Now, in terms of differential diagnosis, children have different differential diagnosis than adults. You may see more metabolic and hereditary diseases. You also may see more vascular malformation in kids. So you always have to think about other neurological disorder that may mimic MS. There are some red flags in the diagnostic criteria. Encephalopathy, we said that. Fever also is a red flag. You have to consider infection or granulomatous disease. If there is a progressive course, then you have to think about hereditary or metabolic disorder. If there is involvement of the peripheral nervous system or other organ, again, you have to think about genetic disease or other disorders. High ESR or leukocyte count, again, infection, autoimmune disease. And if there is markedly elevated CSF white blood cells or protein, again, you have to think about other disorders. And animal spectrum disorder also might be seen in pediatrics, more so also the anti-MOG disorders. So you can see the differential diagnosis for a pediatric cohort is huge. I mean, there's lots of vascular entities you have to think about. So some leukodystrophies and some degenerative disorder. These are usually necessitate some diagnostic more than the adult cohort. Now, if you want to summarize the paraclinical feature that best identify children with MS, probably in pediatric cohort, MRI is probably the most important paraclinical measure that may help us to identify children with MS, and especially black holes. Black holes probably indicative of a chronic inflammatory lesions. So this probably gives us a good indication of dissemination in time. The second important feature is corpus callosum lesion. Dorsum finger are also characteristics. Contrast enhancing lesion becomes third, and then periventricular lesion becomes fourth. And you can see oligoclonal bands is actually not as high in their importance because, as we said before, less than 50% may have positive oligoclonal band. And of course, sometimes you have to do anti-MOG, which are more present in pediatrics, especially if they present with encephalopathy. I'm going to show you some MRI features in pediatric MS. You can see more posterior fossa and spinal lesion. The lesion load is usually very high with minimal disability. You may see tumefactive lesions. And also you may find also poorly differentiated borders of the lesions and frequently confluent at the disease onset in pediatrics MS. Sometimes it's hard to differentiate ADEM from MS with MRI. However, there are some studies that have been done to analyze the MRI scans, and it seems that black holes actually goes more with MS. Periventricular periventricular lesions goes more with MS. And also if you have bilateral distribution, it goes more with ADEM. Again, ADEM needs encephalopathy, and I see lots of reports indicating this is ADEM without encephalopathy. So it's not easy actually to miss that. So I'll show you some MRI differences between MS and ADEM. You can see the MRI ADEM in the bottom, lots of lesions, bilateral, almost symmetrical. You can see the ADEM also involved usually thalamus or hypothalamus, and sometimes the basal ganglia, but more of in a symmetrical fashion. You can see the MS down in B slides, again, large lesions, but asymmetric, more periventricular and also callosal. So in terms of a clinical course, we already indicated before that compared to adults, they may present with the disabling symptoms. They can present with polyfocal presentation, usually affecting the brainstem, spine, or sometimes with also optic neuritis. The relapse rate, as we indicated before, is very high. And usually the time between relapses is shorter in pediatrics compared to adults. And very rarely you're going to see primary progressive MS from the beginning. It's usually a red flag. So we're going to talk about treatment in the last section. I think I have about 10 minutes. So there are some treatment consideration. We already alluded to the fact that the disease of pediatric MS is more active, lots of inflammatory attacks in the system. Also, there is a cognitive impairment. So you have to really hit the disease very hard to avoid the negative impact on the social activity or the school performance. Now, the treatment of pediatric MS used to be based on randomized controlled data in adults. There are a number of class 4 published studies outlining the safety profiles of these drugs. But Fortunately, in the last few years, we had randomized controlled trials of disease-modifying therapy in children. And I'm gonna show you that in a minute. So this is the usual class 4. So if you look at the interferon beta 1A, for example, Avonex, if you look at the studies mostly are retrospective, but look at the number of patients in these studies is very small. So the largest was in the Italian group, and that was a prospective, and it was 77 patients, children. Again, most of these studies were done to not to assess the efficacy, is actually more of a safety concern in pediatrics, especially with the dosing. Again, this is interferon beta 1A sub-Q. Again, look at the number of data. The highest was 51 children. Again, the drugs were safe. Sure, if you look at the annualized relapse rate, for example, it's 1.9, 1.7, or 3.2. So this tells you how high the relapse rate were in these studies conducted in children. Also, natalizumab was also being used in pediatrics cohorts. And this is the largest cohort in Italy, and you can see 101 patients were included in this study. And it was effective. You can see the relapse rate was reduced from 2.3 to 0.01. And also there is an improvement in the EDSS. But again, you can see, given the intense MRI activity, there are a few patients still remain very active with the MRI. And we also did a similar study with natalizumab 4 or 5 years ago, and it showed a similar kind of efficacy. Now, coming to the clinical trials in pediatric MS, there are many drugs being entering into the clinical trials. I'm going to discuss the 3 drugs that probably have published data. The first is fingolimod. This is the Paradigm study, which is a double-blind, double-dummy randomized multi-center. It was oral fingolimod versus interferon 1A. And there were 215 children and adolescents between the age of 10 and 17. And so it was double-blind, and there was a plan for extension for 5 years, also open label extension. And if you look at the characteristics between the 2 groups are probably the same, well, there's no big difference. In each group, there is more than 100 patients. And if you look at the efficacy endpoint, the annualized relapse rate, there is a significant reduction by 82% in the group treated with fingolimod. So this is, by all means, is a very high number in any MS clinical trial, especially if you consider this with a comparator group. And if you look at the time to the first confirmed relapse, again, in fingolimod, more than 85% and the fingolimod group were free of confirmed relapses at month 24, compared to 38% on the interferon 1A IM. So this was a positive study. And in terms of safety, there was no big concern. I mean, the leukopenia and the white cell count reduction were expected with fingolimod. This is part of the mechanism of action. There were a few safety concerns in terms of reported serious adverse events. There were 2 seizures. Now, these were very tough to correlate it with fingolimod. However, the 5-year long-term extension will tell us whether this is really related or not, or this is part of the large lesion you will see with MS. And sure, you may see seizure with MS, but this is not a common presentation early on. The second drug is teriflunomide. The study was Terry Kids, a 2-year randomized double-blinded placebo-controlled. So it was a teriflunomide against a placebo. The teriflunomide group was 109 patients compared to 57 placebo. Unfortunately, although there was a risk reduction in the clinical relapse by 34%, this did not reach statistical significance. And however, all other parameters, if you look at the time to first relapse, there was a significant reduction in the teriflunomide. And also, if you look at the MRI lesion load reduction, there was a statistical significance with 55% reduction. However, the study still at the end was negative because the primary outcome was negative. However, I think there is also an open extension trial. We will get more data. With respect to dimethyl fumarate, there were phase 2 and phase 3 and phase 4 studies. Phase 2 is FOCUS, where you can see the number is 22, and the extension of FOCUS was in the connected trial. Both were completed. Now the phase 3 trial, part 1 was completed, but still part 2 is expected to be completed in 2025. The FOCUS study was primarily a similar design to any phase 2. It was an open label and also mainly to measure the MRI lesion load and the change with the treatment people and also the safety. And it was positive. There was a reduction in the T2 hyperintense lesion in the treatment group. And also the safety profile was very comparable to the adults. There was no red flags. Now the connected, which was the extension, here it shows also there is no red flags, and also the annualized relapse rate continued to decrease. Here there was a clinical endpoint, which was annualized relapse rate, and in FOCUS, if we remember, it was mainly the MRI. And the safety, there is no big safety concern. I mean, the flushing was also very common as expected, similar to the adults. So the phase 3 is still ongoing, but probably we will have data in 2 to 3 years, and the third drug probably going to have a good results based on phase 2 trials. Finally, this is a good review, a literature review and literature search, which reviewed all the studies reporting relapse rates in patients with pediatric onset MS. And of the more than 1,700 studies identified, there were 19 studies. 2 were randomized controlled trials and 7 observational trials, analyzing the efficacy with annualized relapse rates. Now, if you look at the data with this meta-analysis, 11 out of 19 studies, patients were naive, and in 7 studies, patient had a prior MS treatment. And similar to what if we indicated, the relapse rate was very high, and it was approximately 5-fold higher with interferon beta than those observed in pediatric MS treated with either fingolimod and natalizumab. As we said before, natalizumab was an off-label and used in many retrospective studies. So overall, in pediatrics cohort, we think high efficacy medication are probably the best here, given the intense inflammatory process in pediatrics group. Now the questions to be answered, and I think we need more natural history data and also long-term trials. Can the risk of pediatrics MS be modified with the proper vaccination strategies against viral infection or supplementation of vitamin D? And we all know these are big risk factors, and if we change the risk factors, whether we're going to change the actual natural history of MS, this question needs to be answered. If we start high efficacy DMTs early on, will this change the natural history? So this is another question. And whether we should use more intense immune reconstitution therapies earlier on in pediatrics to avoid the cognitive decline and also the accumulation of disability. So I think we need more trials and more natural history data for this. So in summary, pediatric MS is increasingly being diagnosed. There is intense inflammatory and axonal loss at early stages. Pediatric MS is characterized by high relapse rate, posterior fossa and spinal presentation at onset, better recovery from relapse, but slower disease progression. MRI in pediatric MS often has high lesion load with predilection to posterior fossa and spinal areas. Oligoclonal bands and IgG index are often absent, so usually are less than 50% compared to adults. And I show you some new results from randomized controlled trials in pediatric MS, which are very encouraging. With this, I'll thank you for your kind attention.
Thank you, Dr. Rad, for the very interesting lecture. Also very educational in the sense that, we don't usually, even though pediatric MS is common, but, as adult neurologists, we tend to sometimes be a little bit, I guess, sheltered from it. But, we do get them. So it's good to know what are our treatment options. So thank you.
Thank you.
Hopefully you'll be able to stay for the panel discussion after our next speaker.
Sure.
And with that, I'd like to introduce our next speaker. I don't know if she is available, or she'd like to yet. Dr. Kelly Gwathmeh. I hope I'm saying that right. Gwathmeh or
You
Gwathmeh?
are. Thank you.
Oh, you're welcome. It's Gwathmeh, right?
It is. It's Gwathmeh. Thank you so much.
Gwathmeh. Well, thank you for joining us today. So Dr. Kelly Gwathmeh is originally from Richmond, Virginia. She studied neuroscience and behavioral biology at Emory University in Atlanta, Georgia. She then attended Eastern Virginia Medical School in Norfolk, Virginia. Her neurology and clinical neurophysiology training was completed at the University of Virginia. Following this, she completed a neuromuscular medicine fellowship at both Brigham and Women's Hospital and Massachusetts General Hospital in Boston. At the University of Virginia, she started the multidisciplinary MDA clinic, was co-director of the ALS clinic, and was the fellowship director for both the neuromuscular and clinical neurophysiology fellowships. She joined VCU in January 2019 and currently serves in capacity of neuromuscular division chair, neuromuscular medicine program director, and EMG laboratory director. Dr. Gwathmeh sees a wide spectrum of neuromuscular patients and performs electrodiagnostic studies, NCSs, and EMGs. Her research interests include quality of life instruments and autoimmune neuromuscular disorders. With that, she's going to talk to us today about the treatment diagram of myasthenia gravis. Dr. Gwathmeh, the
Thank you
virtual.
so much.
Oh, I'm sorry.
I was going to say, can you see my slides okay?
I see your slides. I hear you well. And I was going to tell you, and I see you now as well.
Okay, perfect.
Excellent.
Well, thank you for the very kind introduction and the invitation to participate.
It's my pleasure, actually. Thank you for coming. And hopefully, I'm excited to hear about myasthenia gravis today. So with that, the virtual floor is yours.
Okay, wonderful. Thank you. And just briefly, disclosures, I have received consulting honoraria from Alexion, argenx, and UCB Pharmaceuticals. And so our objectives today are pretty broad. We're going to quickly look at the pathophysiology, clinical presentation, and diagnostic evaluation of myasthenia. We're going to take a look at outcome measures that may be used clinically to inform medical decision-making and understand the standard of care therapeutics and newer emerging therapies in myasthenia gravis. And here's our outline. So again, just briefly, pathophysiology, presentation and exam, diagnostic evaluation, assessment tools, and treatment approach. So there's a lot of information to cover in 30 minutes. So brief overview here, myasthenia gravis, as you all know, is an autoimmune disorder that results from antibodies directed towards the postsynaptic neuromuscular junction proteins, most commonly the acetylcholine receptor. And when we have the impaired neuromuscular transmission, that results in skeletal muscle weakness. The diagnosis hinges on a combination of the classic symptoms and signs of the disease in combination with these specific autoantibodies. But occasionally the antibodies are negative and we need to rely on our electrodiagnostic testing to make the diagnosis. So we're going to follow a patient of mine that I actually just saw a couple of weeks ago. during the next 30 minutes. So this is a 65-year-old woman diagnosed with acetylcholine receptor antibody positive generalized myasthenia gravis back in 2001. Her initial symptoms were leg weakness, resulting in falling, fatigable shoulder weakness, ptosis, fatigue, diplopia, dysphagia, and dysarthria. Over the years, she was treated with prednistigmine, prednisone up to 60 milligrams a day. She attempted azathioprine without any benefit and required IVIG 1 gram per kilogram every 3 weeks. She had also had a thymectomy in the past, and despite all of this, she continued to have poorly controlled disease. So as we go through this talk, I want you to think about what you would do next in this situation. So again, brief overview of myasthenia in terms of the epidemiology. It's a rare disease with the incidence only 10 per million and the prevalence about 150 to 250 per million. Women are affected more than men, as in most autoimmune diseases, especially in the younger ages, where the ratio could be 2 to 1 or even 3 to 1. But after the age of 40 or so, men become affected more frequently, and then the ratio becomes approximately equal. So the autoantibodies target the neuromuscular junction, resulting in the reduced acetylcholine receptors on that postsynaptic muscle membrane. So looking at the breakdown of the autoantibodies in this disease, we have about 80% of patients who have acetylcholine receptor antibodies, 1 to 10% that have MuSK or muscle-specific tyrosine kinase antibodies, 1 to 5% who have LRP4, and then the remaining have are seronegative, meaning they either have very low level of antibodies that we can't detect with our current testing methodology, or antibodies that bind other components of the neuromuscular junction that are not yet commercially available. So drilling down on the acetylcholine receptor, it's made up of 2 alpha subunits, a beta subunit, a delta subunit, and an epsilon subunit. And the main immunogenic region, which is found in the alpha subunits, which is the target of about 50% of acetylcholine receptor antibodies. So how do these postsynaptic acetylcholine receptors, how are they affected by these antibodies? And it's really through a few different mechanisms. So firstly, if you look to the left of your screen, the acetylcholine receptor antibodies will cross-link the receptors, resulting in endocytosis and ultimately degradation of the receptors. Also, these antibodies will trigger the complement cascade, which results in the membrane attack complex formation and post-junctional membrane damage. So if you look at this electron microscopy picture, it's beautiful from back in 1980. What you'll see is our neuromuscular junction in A of a healthy individual. And you see what we expect to see, which are these postsynaptic clefts that are very deep. And then in B, here on the right side, you see a simplification of the postsynaptic membrane in a patient with myasthenia gravis. And so that postsynaptic muscle membrane really becomes damaged and sort of flattened, if you will. And so you don't have the normal architecture where it allows the concentration of the acetylcholine receptors at the top of those clefts. And then finally, you may have direct inhibition by the acetylcholine receptor antibodies by binding directly to the receptor. And so just to be comprehensive here, our focus today is on AChR positive myasthenia to look at MuSK and LRP4. So anti-MuSK and anti-LRP4 antibodies do block the intermolecular interactions between MuSK and LRP4 respectively. And why this is important is LRP4 and MuSK are both important in the normal maintenance and organization of the neuromuscular junction. It's worth pointing out that MuSK is mostly, the antibody is mostly of an IgG4 subclass, in contrast to AChR positive patients that have IgG1 and IgG3 subclass antibodies. So to transition to the clinical presentation, as you all know, the clinical hallmark is fluctuating and fatigable weakness with repeated activity. So when a patient comes in the door for the first time, they might look quite different than they will look in years to come. So initially, patients tend to have ocular symptoms. Up to 80% have ocular symptoms at the very beginning. So double vision, ptosis, it's usually asymmetrical, fluctuating, and fatigues throughout the day. A minority of patients, only 10%, will have bulbar dysfunction and by way of swallowing and speaking difficulty in the beginning, and very few have axial, limb, or respiratory involvement at the beginning. But things do change over time. So looking at the breakdown in generalized myasthenia gravis across the board, you'll see still the majority of patients, 90%, will have ptosis, 80% diplopia, but now over 2/3 of patients develop dysphagia and dysarthria, and just under a half will develop dyspnea at some point during the course of their disease. Now, over 2/3 also will develop neck, arm, and leg weakness. The arm and leg weakness tends to be weighted towards the proximal muscles. Now, I like to bring in the MGFA, or Myasthenia Gravis Foundation of America classification. Not so much to bore you with a busy slide, but really just to tell you that this is something we use daily in clinic and also, of course, in the clinical trials realm. And it's a nice way to very briefly, succinctly summarize your patient in terms of distribution of their symptoms and how well they're doing. So a class 1 is pure ocular, class 5, you're either ventilated or have a feeding tube or both. And in between, class 2, 3, and 4 are mild, moderate, and severe. And then the A connotation here really denotes that there is limb and axial muscle weakness involvement primarily, whereas B, you can think B means bulbar. So they have oropharyngeal or respiratory muscle weakness primarily. And so if a resident or a fellow presents to me and tells me that Ms. Smith has class 2A myasthenia gravis, I will know exactly what that means. So moving on to the exam, I'm starting off with the eyes. As you all know, that patients will develop or have dysconjugate gaze, especially with sustained horizontal gaze. So we ask a patient to follow our finger with their eyes to the extremes of horizontal gaze and hold it for at least 45 seconds. And then we're timing it, and we write down when the patient develops double vision at 20 seconds, 30 seconds, or 50 seconds with sustained horizontal gaze. We expect myasthenia gravis, of course, to spare the pupils. And when they have double vision, it does not tend to follow a cranial nerve distribution. Now, unlike the arm and leg muscles, ptosis tends to be asymmetrical. It can even be completely unilateral and tends to fatigue with sustained up gaze. So similar to testing for fatigable diplopia, we ask a patient to look up at our finger for at least 45 seconds, and we look to see if they develop ptosis. And then patients may also have weak eye closure that's quite commonly encountered. When we think about examining their faces, they often have significant facial weakness, almost facial diplegia, and they may have a myasthenic snarl because of the difficulty actually expressing themselves with a smile due to weak facial muscles. They may have a nasal speech pattern that worsens as you interview them, and their palate might not elevate it. We often see that their tongues are very weak, and the way that we test this is have the patient push their tongue against the inside of the cheek, and then the examiner provides some resistance on the outside of the cheek to test their strength. Neck weakness is commonly encountered and is quite concerning when you see it, as we know that neck flexion weakness specifically correlates with diaphragmatic muscle strength, and patients may even present with a dropped head. And as I mentioned, when we see extremity weakness, it tends to be more heavily weighted towards the proximal muscles. Now, we can divide our myasthenia gravis patients up into subgroups, and there are a number of different ways we can kind of slice and dice this patient population. First, by age of onset. So you can have your early onset myasthenia gravis patients and your late onset myasthenia gravis patients. And arbitrarily, it's kind of cut off around age 50. In the earlier years, in the early onset myasthenics, it tends to be female predominant, and they often have thymic hyperplasia. Whereas, as I already mentioned, in the later onset MG patients, you see more men affected, and then there's often more thymoma encountered, which we'll get to momentarily. You can also divide myasthenia up based off of the distribution of manifestations. So patients may have pure ocular myasthenia. I know we've been talking a lot about generalized myasthenia. Important not to forget that 15 to 20% of our patients continue to be ocular. So if you make it to the 2-year mark and have not generalized, then you're in pretty good shape. We don't think that you will generalize much beyond 2 years. And then remember that about 50% of our patients with pure ocular myasthenia gravis do not have detectable acetylcholine receptor antibodies. As mentioned, we can subdivide our patients based off their thymus gland status. And so 10 to 20% of patients will have a thymoma, and that will come out if they do. And then more commonly, when we encounter, especially in our younger patients, thymic hyperplasia. We can subdivide our patients based off of their serology. So we're going to spend most of the time today talking about acetylcholine receptor antibodies. Don't forget that we do have patients with MuSK myasthenia as well. These patients can be divided into two big categories: the ones that look just like our AChR positive patients, and those that have a very severe craniobulbar presentation. They may even have tongue atrophy. LRP4, we're still trying to understand that phenotype. In general, it might be mild generalized or ocular symptoms. Sometimes you see double seropositive patients that overlap with AChR positive, and then they're going to have more complete generalized disease. Seronegative can run the gamut from very mild ocular symptoms all the way up to severe treatment refractory generalized disease. And with that, we will transition over to the electrodiagnostic testing. I'm going to keep this very brief and not touch on single fiber EMG in the interest of time, but I think it's important just to remember some of the basics here. So remember, the neuromuscular junction is really an electrical, chemical, electrical link between the nerve to the muscle. It's how the nerve talks to the muscle, right? And so the neurotransmitter here is acetylcholine, which is packaged in quanta or vesicles in that presynaptic terminal. Now remember that we all have three different stores of acetylcholine: the immediate or primary store, which springs to action immediately with just 1,000 quanta of acetylcholine, secondary mobilization store of 10,000 quanta, and the tertiary or reserve store of more than 100,000 quanta, which is far from the neuromuscular junction. So when the nerve depolarizes, the calcium channels activate, and you get this influx of calcium that then in turn results in the release of the acetylcholine from that presynaptic terminal. As the acetylcholine diffuses across that synaptic cleft, it starts to bind to the acetylcholine receptors. With the binding to the receptors, the sodium channel is open, and that results into polarization called the in-plate potential. Now, if the in-plate potential reaches threshold, it generates a muscle fiber action potential. So in normal, healthy human beings without myasthenia, slow repetitive nerve stimulation will allow the acetylcholine to slowly deplete from that primary store. Now, the in-plate potential falls in amplitude, but because we have a safety factor, we have extra receptors, right? It does not drop below the threshold, and we still are generating muscle fiber action potentials. And therefore, when we stimulate a patient with repetitive nerve stimulation testing, there's no change or decrement in the amplitude or the area of that compound muscle action potential. And then in a few seconds, secondary mobilization stores come in and replace that depleted quanta. Now, not true in those patients with generalized myasthenia gravis, right? So 50 to 70% of patients will have abnormal repetitive nerve stimulation testing, depending on which nerve you choose. And the idea here is that safety factor is reduced due to less receptors at that postsynaptic membrane. And so as we use this low repetitive nerve stimulation testing, we're depleting that quanta and reducing the amplitude of the in-plate potentials. And no longer can it reach the threshold, and the muscle fiber action potentials cannot fire. And that results in a lower amplitude CMAP. Okay, this whole idea behind electrodecrement, which you see here on the figure on your left, when we're stimulating multiple CMAPs in a train, and we're looking at a greater than 10% decrement between the first and the fourth CMAP. And this is the electrophysiological equivalent to muscle fatigue and weakness. So back to our case briefly. So just in January of this year, our patient came into clinic and she said, I'm doing worse. I have worse slurred speech, chewing and swallowing difficulty, worsening dyspnea, double vision. And at this time, she's already on IVIG, about 1 gram per kilogram every 3 weeks, 20 milligrams of prednisone, and 120 milligrams of prednisone 3 times a day. So her myasthenia gravis activities of daily living scale and her quality of life 15 scale were 8 and 15 respectively. So what are these? We'll get to that in a minute. And we did check her respiratory numbers while she was in clinic, and her vital capacity was 47% of predicted. So off she went to the hospital and received another 2 grams per kilogram of IVIG. So more to come on her. So briefly on to myasthenia gravis outcome measures. So anyone who works with me knows I'm a big fan of collecting data. And so I really feel like these outcome measures in myasthenia gravis can be used clinically in addition to in the clinical trial setting. And a beautiful example of that is the myasthenia gravis activities of daily living scale. So you see that there are 8 items here with 4 different category responses. And you basically ask the patient how they've been doing over the last several weeks and tally up their score. And so at our institution, we track these scores over time to determine if we need to escalate therapy or not. This is also the most commonly used outcome measure in clinical trials these days. The myasthenia gravis quality of life instrument, the revised version, which we worked on back in 2016, is also a 15-item instrument, patient-reported, health-related quality of life instrument that's disease-specific to myasthenia gravis, unlike like the SF-36, which you may be familiar with. So 3 category responses here, 15 items. It takes about 5 minutes to administer and can be extremely useful. Now, the quantitative myasthenia gravis score is a very formal examination, okay? So this is something we use all the time in clinical trials, but we don't use so much in the clinic setting just because of the time it takes to conduct this, okay? But I show it to you here as a very important tool that can be used, especially in the clinical trials realm. So how do we treat patients with myasthenia gravis? And I want to start off with this. So remember that we have an international consensus guidance that was published in 2016 and updated in 2020. And the idea here is the goal of treatment is to achieve remission or minimal manifestations with minimal side effects. So I find myself saying that at least once a day. I said it yesterday to a brand new myasthenic patient. Like, this is our goal. This is what we're going to be working towards. So how do we get there? And then this is just briefly the reference of the 2020 update. So first, I wanted to just briefly touch on thymectomy because it's sort of stands alone and separate from the therapeutics that we use. So recall that in the New England Journal of Medicine in 2016, the randomized trial of thymectomy in myasthenia gravis was published. And we certainly don't have time to go through the nitty-gritty detail of this study, but it was international and it was a double-blind randomized trial looking at thymectomy and prednisone versus prednisone. And patients who had had a thymectomy, these are AChR positive generalized myasthenia gravis patients. These are patients who had a thymectomy who didn't have thymoma, found that these patients had milder disease, less exacerbations, and were on a lower dose of prednisone. So overall, they fared much better. And so today in 2022, the standard of care is if you have AChR positive antibodies and generalized myasthenia gravis, and you're under the age of 50, because we feel like that's about the cutoff of when it becomes less effective, we offer you a thymectomy, okay? And so moving on into the medications, and I'm not going to sit here and read these slides to you, but it's really for your reference. Practically every patient who comes in the door with myasthenia gravis, no matter what the flavor, gets started on pyridostigmine. And why is that? It's the most commonly used acetylcholinesterase inhibitor, starts working fast within 30 to 60 minutes and lasts about 3 to 4 hours. So it's really symptomatic management. It's not changing your immune system. It's not treating the underlying disease. It's just giving you an extra burst of acetylcholine at that synaptic cleft. And so I always say it's kind of like putting a Band-Aid on the problem, but not really fixing the underlying wound, right? So then most patients go on to get corticosteroids. And why is that? Because it's inexpensive, it starts working relatively quickly, and it's highly effective. So patients who start on corticosteroids, in our country, it's prednisone, it starts working within about 2 to 3 weeks. And so some patients will have to be titrated all the way up to 60 to 80 milligrams, per day. And it's worth mentioning that patients may, in theory, have an exacerbation of their symptoms within the first 7 to 10 days of initiating, especially high dose corticosteroids. And so usually I start at 20 and gradually increase until they start to improve, and then start a slow taper. And not to get into this too much either, but it's worth pointing out that this wonderful paper was just published in JAMA Neurology, comparing 2 different tapering regimens of corticosteroids in myasthenia gravis patients, 117. And they looked at rapid tapering versus slow tapering. And I was always brought up to do the very, very slow taper. But this group found that the rapid tapering regimen enabled an even faster prednisone discontinuation before 1 year, and with a 4-fold increase in the proportion of patients having reached minimal manifestation status at 12 months, not receiving corticosteroid therapy, and without relapse by 15 months. And so the references here, please pull this and consider using it. I have not yet though. And then there are a whole host of different steroid-sparing immunosuppressant therapies. In the US, the top 2 for us are mycophenolate and azathioprine. The problem with these medications is that it takes a long time for them to kick in. It can take 8 to 12 months for mycophenolate to kick in, right? And so you have to be patient. So if someone's unstable and in front of you, this is not your go-to medication, right? This is more of a long-term investment. And these medications certainly immunosuppress you. They require lab monitoring. There's the potential for skin cancer, lymphoma, et cetera, et cetera. So they, require some work in some patients. Methotrexate, it is a folate antimetabolite that has wide-ranging immunosuppressant mechanisms, has a very long list of potential side effects. And then this is from our international consensus guidance that even though we don't have any great randomized clinical trial data to support using methotrexate, if patients can't tolerate or have failed some of the other steroid-sparing agents, perhaps we can still consider it. And with that, I'll remind you, we did have a randomized controlled trial published in 2016 that didn't demonstrate any steroid-sparing benefit for methotrexate. And in the interest of time, since this is just such a brief talk, I included this table that was published in Drugs in 2022 by Dr. Menon and Brill that really just goes through our standard treatments of the classical medications that we use for myasthenia gravis, how long it takes to kick in, and the dosing range. And then we're going to just move on to some of the newer therapeutics. So rituximab. So it's an anti-CD20 antibody. We use it all the time in the US in MuSK myasthenia gravis. And you'll see on the right here.
Remaining.
Okay, thank you. You'll see that we use it for MuSK and it's recommended, whereas the jury is still out whether or not it's helpful in acetylcholine receptor positive patients. This data was presented years ago, but this is the BEAT-MG NeuroNext study, phase 2 NIH-funded clinical trial looking at rituximab and AChR positive GMG, did not demonstrate that patients on rituximab had any steroid-sparing benefit compared to patients not on rituximab. And then my case continued. My patient was started on eculizumab following her hospitalization, and I saw her after 2 induction doses back in clinic, already improving in terms of double vision, slurred speech, swallowing and breathing, and extremity weakness. Her ADL score and QOL-15R were both 6. So what's eculizumab? So it's a humanized monoclonal antibody directed against C5 complement. So it really inhibits the cleavage of C5 to C5a and C5b, and ultimately the formation of that destructive membrane attack complex, as I showed you previously. It is approved for PNH, paroxysmal nocturnal hemoglobinuria, atypical hemolytic uremic syndrome, and generalized myasthenia gravis. And this is just your complement pathway and where it works right on C5. So briefly, we're going to touch on the REGAIN study. This is a large phase 3 randomized double-blind placebo-controlled study looking at AChR positive generalized myasthenia gravis patients who were considered to be refractory. So this study was conducted at 76 sites in 17 countries. You had to be 18 or older to get in. You needed an activity of daily living score of 6 or greater, and you couldn't have ocular, and you couldn't be ventilated or have a feeding tube. So refractory for this trial was considered to be patients needed to have been on 2 or more immunosuppressive therapies, or 1 immunosuppressive therapy and IVIG or Plex intermittently for a year without adequate control. You couldn't actively be on IVIG or Plex and get into the study. 6-month washout for rituximab, couldn't have had a thymoma, and you couldn't have had a recent thymectomy. So it was a 26-week study, 1-to-1 randomization, eculizumab to placebo. So in the interest of time, I'm just going to briefly state that it's very, the jury's still out on the exact definition of what refractory disease is in myasthenia gravis. It could be you don't respond to standard treatment, you have side effects to standard treatment, you require too high of doses and it's causing significant harm to you, you have comorbidities that don't allow you to participate in conventional treatment, or you have frequent crises or need rescue medication. And we think the refractory population makes up to 20%, more common in young women or in those with a history of thymoma or MuSK. And there are numerous publications written on really trying to define and understand this refractory population. So going back to the REGAIN study, patients were treated with 4 weekly doses of 900 milligrams, then 1,200 milligrams a week later, and then every 2 weeks after. And the primary efficacy endpoint for this was going back is that MG-ADL, the Activities Daily Living Score, baseline to week 26, eculizumab compared to placebo, based off worst rank in COVA. And there were a number of secondary efficacy endpoints. I'm not going to read you, but you'll see some familiar names here, a lot of the outcome measures that we've already touched on, and these were interpreted based on hierarchical testing methodology. We had 63 patients in the placebo group and 63 on eculizumab. Now you'll see for the pre-specified worst ranking COVA score, for the ADL, we just missed statistical significance on the p-value. QMG made it, MG composite just barely missed, and QOL 15, not the revised version, was statistically significant. Looking at the responder analysis, these are Christmas tree plots. In blue, we have eculizumab. In red, we have placebo. These are the point changes on the ADL, point changes on the QMG, and you see for every cutoff, more patients, significantly more patients in the eculizumab arm responded compared to placebo, and you see this was clearly statistically significant across the board. And this is a very common scene for those of us who look at a lot of myasthenia gravis trials. The big outcome measures, ADL, QMG, MG composite, which we didn't talk about today, and the quality of life instrument. Red is placebo, light blue is eculizumab, and you see an almost immediate separation between the placebo and treatment arm in terms of these outcome measures out to week 26. And finally, my patient seen back 2 weeks ago, now status post her induction treatment with eculizumab and now 3 maintenance doses. Her ADL has come down to a 1. Her quality of life score has come down to a 5, and her breathing numbers, she's at 80% predicted on her vital capacity. And my final slide, last 2 slides here is really just to introduce ravulizumab. So this was just FDA approved in the United States. So ravulizumab was engineered, it's the next generation of complement inhibitor, to maintain therapeutic serum concentrations over 8-week dosing intervals. So you induce the patient, give them another maintenance dose 2 weeks later, then every 8 weeks. So they're only getting infusions once every 2 months. And this is a familiar slide to you. You just saw something look very similar from the REGAIN study, but the primary efficacy endpoint here was the MG-ADL, which you see up here in A at week 26, with significant separation between the placebo and ravulizumab arm, with a statistically significant difference in the score at week 26. And I won't go through all of this in the interest of time, but I do appreciate your attention and look forward to taking any of your questions.
Thank you very much. Very nice review of myasthenia, and very quick review of all the medicines and treatments. So much appreciated. So with that, I think we can invite all the speakers back for the panel discussion. Dr. Levy and Dr. Raed. Everyone here?
I am here, yes.
There we go. Excellent. Welcome back, everyone. So for Dr. Levy, start with you, just because I know you may need the...
Thank you, Dr. Levy, for coming back. Yeah, we'll start with your questions. Only one or two.
So first question is, for NMOSD patients who are stable on Rituxan, would you recommend them changing to some of the newer agents?
That's a question a lot of my patients ask me because they've been stable for so long. They want to know why they should change. And for most of them, I would say they don't. I tell them about all the new drugs and the wonderful science that backs them up, and the observational data that we have for rituximab, which is not as strong. But in their experience, they found remission with rituximab and very few will switch. So it's hard to convince them to, even though the science backs up the approved studies.
Okay. So if it ain't broke, don't fix it. Question here. What about pregnancy? How do you approach that with NMO?
Pregnancy, we use both rituximab and eculizumab through pregnancy, and we haven't seen any adverse events related to either the mom or the baby. In fact, if you don't use medication through pregnancy, there's a high risk of relapse in that third trimester or postpartum. So we don't recommend stopping treatment, but azathioprine and especially mycophenolate are thought to be harmful, and so we don't use those two drugs.
Okay. Now,
so if a pregnant lady, is on azathioprine or mycophenolate, you will switch them, and then you will switch them back, or just keep them on the new medication then if they had no relapses?
Mycophenolate is specifically contraindicated for pregnancy because there's a 15% risk of facial deformities and things like that during pregnancy if you're on mycophenolate. So we specifically recommend against that and stop people, especially if they're pregnant, stop their mycophenolate and switch them to something like rituximab or eculizumab. And after pregnancy, if they want to stay on the treatment they're on that works through pregnancy, that's fine.
Okay.
And given the fact that azathioprine and mycophenolate really take long to work, I mean, from really practicality with a very severe disorder like NMO, and you're diagnosing them even after the first episode of, for example, area postrema and a positive antibody, would anybody choose mycophenolate or azathioprine, since it will take a long time really to suppress the immune system, and you risk having relapses in that period of 6 months until they work?
I completely agree with you, but azathioprine is still the most widely used drug for this condition in the world because of its availability, its price.
Right.
And so for most of the world, azathioprine is still the go-to drug. But for all the reasons that you explained, it's really the worst choice.
Thank you. We don't use it in pediatrics, at least.
I think with that, no more questions for you, Dr. Levy. So I would like to, I know you may need to leave a little earlier. So I just want to tell you thank you very much for your interesting lecture, and maybe we'll see you in Dubai if you ever pass by.
That would be lovely. I'd love to visit.
We'd love to have you.
Take care. Thank you.
Bye-bye. Dr. Raed, are interferons dead for pediatric MS?
Huh?
In regards to MS in pediatric, is there still a role for interferons? Or do we now go to the orals and high efficacies?
Well, I think the evidence now goes with high efficacy medications. Now there is fingolimod has been approved for pediatrics, so this is the only approved medication by clinical trials. And most of the data I showed is probably favoring high efficacy medication. Natalizumab is the second. B-cell depleting therapy are probably also there. So rarely we use interferons nowadays.
unless maybe someone can't handle the orals or there's some contraindication.
That's correct.
I'll ask a
Yeah.
question while you handle all the rest.
Yes.
Ahmed. I know there's lots of online questions. For Dr. Raed, I want to ask you a question. Actually, I agree completely with what you the point you raised about the incidence and prevalence and, the different criteria used and the different age cutoff and so on. But when we studied our population here in Abu Dhabi, we found that the incidence was higher than the rest of the world. And you mentioned a Kuwaiti study as well. Did you find something similar that, makes our population? I know there's not many studies really in the area, but
yeah, we actually did a epidemiological study in the pediatric onset, and we found the incidence is around 7 per 100,000. This is our incidence rate in Kuwait. Now the prevalence changing, but as you know, the peds also grows out, and then they will be counted in the adult. So that's the tough thing.
Yeah.
I mean, it depends on the age cutoff. When we studied our cohort, there were 7% of the pediatric cohort from the whole MS registry.
Sure,
we have MS registry now going almost 13 years.
Wow. And I think another confounder that you alluded to was that most children with relapsing demyelinating disorder were counted as MS before we knew about, MOGAD. And now, I think also us being more courageous with the using the McDonald 2017 criteria, especially in the post-pubertal kids, I think we're going to see different data maybe in 10 years from now, having more accurate data and diagnosis. So
I agree. I mean, we're going to see more children with MS, especially when you use the updated data. Not much CIS, not much ADEM. You will see more MS.
So, very good. Dr. Kelly. In regards to the acetylcholine receptor antibody, first of all, thanks a lot for the interesting lecture. For the acetylcholine receptor antibody, if it's negative, but you've proven that this patient has MG by neurophysiologic testing, any benefit on rechecking? Does it change your treatment?
Oh, yes, absolutely. So a lot of times, is an excellent point that I failed to make. So thank you for asking the question. A lot of our patients who initially are negative will flip positive, especially in the first year or two. And so a patient I saw yesterday morning who presented with purely ocular symptoms was seronegative 9 months ago. I strongly think she's probably converted as she's now generalized. And so there is value in repeating that testing because it opens up the door to our newer therapeutics. So 100% would strongly recommend it.
Excellent. Very good. And then there's a question about, I don't have much experience with it. Do you VYVGART?
Yes. Is there a specific question about it?
Basically, it's kind of open, like it's relatively new. Any experience? What are your thoughts on it?
Yes. So VYVGART was FDA approved in the US, efgartigimod, in December of 2021. It's an FcRn inhibitor. So to very simply put it, I think of it as similar to chemical plasma exchange. It pulls antibodies out of circulation. And so it's for myasthenia gravis, currently it's FDA approved as an infusion that's given weekly for 4 doses. And then it sort of cycles that repeat. We have experience with it in the clinical trial realm and another disease state and CIDP in clinical trial, as well as clinically, we now have a few patients on the drug. And it drops the IgG levels very quickly within a week or so. And it seems to work nicely very quickly as well. We're still gaining experience with it. I can't tell you I have a wealth of experience, but so far people are tolerating it. I will say, in contrast to the complement inhibitors, I think the thing that makes that we're still unsure about is the cycles are variable. So some people might need a repeat of their cycle in 8 weeks or 12 weeks after their first cycle. And so not knowing that makes it a little bit challenging to coordinate in the infusion center and with insurance and that sort of thing. So
looking forward to seeing some experience coming on with time.
Dr. Kwatmi, can we apply all what you said in today's night, which is really a lot for anyone to handle, I think. Thanks God I'm a pediatric neurologist, because I don't see much of that. I do have a few patients with, myasthenia. Can we apply whatever you said to children as well? Or apart from the medication that's not approved? I mean, in terms of, I know there are also guidelines for juvenile myasthenia, but I mean, even for adults, what you presented, generally we think of neuroimmunology as hit early, hit hard. However, with myasthenia, it's kind of really very tricky, because you don't know, like you said a very important principle, which is you want to get them into symptom control or remission, but with the least side effects. And the range of treatment is just tremendous. So how would you counsel your first visit patient after the diagnosis is confirmed? And, with all these medications up to the thymectomy, is there an easy recipe, a summary in 1 minute that you can get us to take out of your lecture?
You mean in terms of if I were counseling a child with myasthenia specifically,
or
or
know,
just
maybe child is harder or different, but even an adult, I mean, it's probably kind of similar approach.
Right. So I would say just sort of two different answers here quickly. In terms of the pediatrics, I don't do much pediatric MG anymore. I used to do it quite a bit. And we'd always try and get away with using pyridostigmine monotherapy if at all possible. We try not to use high-dose corticosteroids for obvious reasons. And then a lot of our steroid-sparing immunosuppressants we would not use in children. And so in patients who needed more than very low-dose corticosteroids and pyridostigmine, I tended to use maintenance IVIG. And, tended to be well tolerated, especially for patients who are more severely affected. And most of those children had their thymus glands taken out. So to answer the pediatric side of it, and you're right, the newer therapeutics right now aren't FDA approved in the US. And then just in 1 minute, how do I sort of briefly counsel patients? First of all, it takes me about an hour to get through a new myasthenia counseling session. But in 1 minute, I tend to say right now, what we're doing in 2022 might look completely different than what we do in 2025. And so the general algorithm is pyridostigmine followed by corticosteroids, maybe simultaneously, with the idea that we transition to a steroid-sparing agent and then taper off the pyridostigmine and the corticosteroids, right? So it's sort of the long-term plan. So where all these newer therapeutics are going to get inserted into our treatment algorithm really remains to be seen. I think they can serve many different roles as bridge therapy to oral immunosuppressants. They could be used in very unstable patients and refractory patients, or as you already pointed to, perhaps we should be hitting hard and hitting early so people have better outcomes. So why are we going to wait a year for that mycophenolate to kick in? And so jury's still
like
out.
You said, also a thymectomy for those with generalized acetylcholine receptor positive antibody within 1 year of diagnosis, right?
Once they're medically stable, yes. Once they're medically stable,
avoiding
and then
all the long-term immunotherapy, hopefully as well.
That's right. And then, yes, exactly. And then hopefully if they're on less than, say, 20 milligrams of prednisone a day for wound healing purposes and that sort of thing.
Can they be stable on monthly IVIG or?
Oh, that's another controversial question. I love that. So back maybe 5 years ago, my refractory patients were often on maintenance IVIG out of necessity, and less likely on maintenance plasma exchange. I think with these newer therapeutics like eculizumab, it's allowed me to transition almost all of those maintenance IVIG patients off of IVIG onto eculizumab, which has been successful.
Which can be used in children. I know it's not labeled for myasthenia, but it's used for hemolytic uremic syndrome in children.
You're right. You're right.
Dr. Any experience with cladribine in your pediatric kind of transitioning into adult MS patients?
No, unfortunately, no. We haven't used it for less than 16 years of age. I don't think we have data. There is no still real-world evidence also behind this. So Probably we're going to use it sometime, but until now, no.
But less than 16, you haven't used, but 16 to 18,
16
you
to 18,
had?
we used it, yeah.
Okay.
Similar to also alemtuzumab. So both immune reconstitution therapies, we use 16 or above.
Okay. And then here's a question about just more about the diagnosis. So if someone has a brainstem relapse and then a month later they have a spinal cord relapse, 30 days later, do you consider that 2 relapses or just one multifocal relapse?
2 relapses.
2 relapses.
If there is a separation for encephalopathic, then you have 3 months. But for non-encephalopathic, 1 month is enough for dissemination. To call it a second relapse, you need only 1 month.
1 month or 3 months for encephalopathic. Very nice. And I think
that crop 2013 needs updating really, because so much has happened since then, right?
Yeah, I mean, if you look at the crop, only the addition in the crop is the encephalopathic kind of pattern, but most of the crop is actually similar to McDonald's 2017.
Except that when it talks a lot about ADEM, it does not really involve MOG, which is really a completely different entity, separate to ADEM and separate to MS. That has not been addressed.
Correct.
I think right here we got one final question for Dr. Kelly. Ocular myasthenics, do they undergo thymectomy, or do you follow them, or what would you recommend for those patients?
I'm sorry, what type of myasthenic?
Ocular myasthenia.
Oh, ocular. I mean, certainly you could. I mean, in someone who's seropositive, I mean, if their treatment isn't going well, maybe. I would say most of the ocular seropositive patients, I feel like we're very successful in treating with minimal therapies. Yeah. So, I mean, certainly I think you could justify it if you were having a difficult time treating them, but we think of it more as a tool in generalized myasthenia.
Got it. I think that's it. I know we went through like a lightning round of questions with you and Dr.
You did very well.
Well, thank you all. You both did amazing. Thank you. It was a pleasure having you. Ooh, inshallah, hopefully we'll see you guys in Dubai.
Thank you so much again.
Thank you very much.
It's our pleasure.
Thank you.
Thank you. Thank you.
Bye-bye.
So for the audience, we'll see you again tomorrow. We will be starting at 5:30 for the
Yep. So tomorrow we will be starting at 5:30. We've got again 5 lectures. We've got our progressive neurologic disorder sessions, and we got our multi-system sessions. So a lot of interesting speakers, interesting topics. Please join us tomorrow. Looking forward to all the questions you guys have. And with that, any questions, Dr. Jihan, you would like to? Any questions? Any comments you would like?
Have a good night, everyone. Thank you, Jared, and the team.
Yes, thank you, Gerard.
And to all our speakers.
Thank you, everyone.
And to the audience.
Amazing first day, and much appreciated. And thank you, audience. It's always fun. مع السلامة. Bye-bye.